welcome everybody to this special occasion. This is our annual Meiklejohn lectureship in honor of Dr. Gordon Meiklejohn. So Dr. Meiklejohn was the founding department chair of the modern Department of Medicine. He took a pay cut to come here and take the job and had a half a dozen faculty when he arrived. He recruited the best and the brightest from around the country and built the modern Department of Medicine. So at the point where he retired, we had 90% of the current divisions in place with young dynamic leaders. Dr. Meiklejohn was chair for more than 25 years. He grew the department, I don't know, 1,000% over the time that he was here and really put the department on the map nationally and internationally. He himself was a pioneer. He was involved in the international effort to eradicate smallpox. He was a pioneer in the creation of the flu vaccine. On a personal level, he was known to be an incredibly kind and generous man, and somebody who really fostered the values of academics and personal growth in the residents, students that he mentored, to the faculty that he brought on. He was still active in the department when I got here in 1990 as an intern and came every week to Grand Round, sat on the front row, and often asked the first question. So this is in honor of his legacy and his memory, and we're fortunate to have his daughter and her husband, members of the family here today. So thank you all for being here. Part of the Meiklejohn Endowment allows us every year to invite somebody that we are excited to have come spend time with us. And this year, that is Dr. Adam Cifu. Dr. Cifu is originally a New Yorker. He went to Haverford for college, Cornell for medical school. He went to Beth Israel for his residency and for a primary care chief residency, and then navigated with his wife a little west to Chicago, where he's been ever since. And Dr. Cifu has a very distinguished record as an educator, as an intellectual and a thought leader. As you can see from his title, he comes up with very thoughtful and provocative ways to make us think differently about what we do in medicine. So it is my pleasure to welcome Dr. Cifu today as our annual Meiklejohn lecturer. So thank you for being here.
Thank you so much. I am grateful, flattered, and sort of awed hearing about our lectureship. I'm looking forward to reading it on the way home. I love things like this we were talking before because they always feel like you're carrying on both the history and the culture of the institution. I think it's so important. And so just puts more pressure on me to do a reasonable job. So I'm going to talk about George Orwell and the clinical presentation. This is one of those talks. I think you will learn no medicine from this talk, but I'm hoping that it sort of makes you think a little bit differently about the language that we use, and maybe changes a bit, or I don't know, rededicates you to good medicine. I put up here, my backup name is going to be an old curmudgeon, because you might listen to this and be like, "What is this guy talking about?" But bear with me. I'm really a nice person. Where does this thought come from? I think that we all listen to a ton of presentations, we watch a ton of physical exams, we read assessment plans, or we listen to assessment plans as we round with trainees. And usually you're paying attention, right? And you're saying, I got to figure this case out, I got to think about what we're going to do here. But occasionally you get distracted by sort of what you hear, what you see, what you read. And so the thought was, could we do better and sort of practice better medicine if we paid more attention to the way we communicate? And so that was the idea behind this. So I'm going to ask you to sort of put yourself in this situation, right? That we've all been in this situation. And you can make yourself this instead. Okay. Sorry. Yeah, you're right. Seems dead. Oh, you know? Actually, there we go. Just needed a restart. I could? Okay. So picture yourself here, okay? And you can picture yourself as anybody in this picture. think it was probably created with AI, so it's unclear who's who. But you could be the intern, the medical student, the patient, the attending, whatever you want. And the presentation begins. AP is a 56-year-old white male with a history of hypertension, diabetes, inguinal hernia repair, tonsillectomy, and onychomycosis, who came in complaining of 5 days of chest pain. He first noticed the pain when he was driving home from work. He endorses headache, but denies dyspnea or diaphoresis. He's supposed to be on HCPZ, but he is non-compliant. His past medical history is as above. He lives alone, drinks socially, and is recently retired. Review of systems is unremarkable. Do you want to hear his medication? On physical exam, his vital signs were stable. He has decreased breath sounds bilaterally. There was a 2 out of 6 heart murmur. Abdomen was soft with tenderness in the right lower quadrant. There was no rebound or guarding. There was 2+ bilateral lower extremity edema. You can see his labs here on my tablet. You hold out an iPad or phone or whatever you're using at the time. And then we go on to assessment and plan. For his chest pain, murmur, edema, we're going to do a PE protocol CT and an echo. We will scan his belly given the abdominal tenderness. If he spikes the fever, we'll get ID about that. So hopefully that irritates you a little bit. I think, you know, as you hear it, you'd say, well, that's an exaggeration. But all of us have either said or heard, you know, something from that presentation. I will perfectly say that I am, you know, as culpable as anybody at cheating and using some of those terms. I hope there's one thing that got under your skin, and if there was not, I will try to convince you that maybe there should be, or you should be irritated about more things. And for the questions, which will sort of be my outline, I think, for the talk, is why does our language sound the way it does? And how do we end up here? How do we use language to signal to others, maybe to patients, to our colleagues, to demonstrate our knowledge, to kind of defend our actions, what we plan to do? And then I think maybe most importantly is how does our language predispose us to making errors, especially overuse? I am, as I will talk tomorrow, I am really interested in the things we do for no reason, the things we do when we think we have a good reason, but then we find out that the reason we do things is wrong and have to go back on it. And I think a lot about like, how does language get involved in that? And then also, how does our language interrupt our relationship with our patients? And I think this has become a lot more interesting lately because it used to just be how we talk in front of patients. But now with all the open charts and such, it's also how we document. You know, more and more I get calls the day after a visit, not only with a frantic, you know, my GFR is low, what's going on? But also with, you said this is wrong. And sometimes it's wrong, sometimes it's just that, you know, we speak, we write in ways that are different from, you know, normal human beings. So this is my defense for maybe being a curmudgeon, and this is where we get to Orwell. This is a wonderful quote from him. I'll just read it. Most people who bother with the matter at all would admit that the English language is in a bad way, but it is generally assumed that we cannot, by conscious action, do anything about it. Our civilization is decadent, and our language, so the argument runs, must inevitably share in the general collapse. It follows that any struggle against the abuse of language is a sentimental archaism, like preferring candles to electric light, or a hansom cab to airplanes, or maybe listening to the heart rather than using a bedside ultrasound. Underneath lies the half-conscious belief that language is the natural growth and not an instrument which we shape for our own purposes. Comes from this wonderful essay, Politics in the English Language from 1946. If you haven't read it, it's an amazing essay, quite short. Clearly was written while Orwell was working on 1984, which came out in 1948. And so a lot of the ideas of sort of double speak and being able to control thought by being able to control language are sort of wrapped up in this essay without a lot of the, you know, dystopian side that gets involved in 1984. This is actually the book I first read it in. I read it in a 10th grade class on the modern essay, and this was our textbook for the class. I had to pick that up on Amazon. So let's start with the presentations. we say some strange things if you think about it in the presentation. Our language is alive. Anything that's alive, accumulates imperfections with time, I guess, sort of like seborrheic keratosis or something. And so it's interesting to think about, like, so how did this happen? I think the biggest things are, we try to sound smarter than we are. We use language as a bag of belonging. It's kind of the acculturation or the socialization of us as we become physicians. It does threaten the doctor-patient relationship, and it also frequently reveals kind of laziness and imprecision in our thought, which can be dangerous. So first, the efforts to sound scientific, and just a couple of examples, and you guys, I'd be happy for you to argue with me, but things that we say, which, like, why do we say these things? We refer to people male, female, rather than men, women, bilateral lower extremities instead of both legs, right? That's 3 words and 10 syllables instead of 2 words and 2 syllables. I put a bunch of sort of, they're more for further reading than real references at the bottom of these slides. Robert Hirschdeck, who's still at Northwestern, wonderful, brilliant writer, and for a while must have had a very close editor at JAMA because he published about 6 piece of my mind articles in 3 years, just sort of reflecting on medical practice. And he has a couple brilliant ones about language. Orwell says, orthodoxy, whatever colors, seems to demand a lifeless imitative style. And we certainly imitate people who we respect in how they talk and how they present. Our language also shows kind of mastery of our medications and situations, right? My residents always talk to me about, metope, ACEs, ARBs, GDMT, and some of these things, every time I go on service, they've changed. And I was like, why do we say metope and not metoprolol anymore? Are we saving that much time? Sniff, R, DDT. Sniff was something that I was comfortable with. R and DTT were new things when I was on service this block. And I'm always sort of, I feel like my time on the inpatient service is a little bit of continuing medical education for me these days. And so I'm always a little bit shy about asking and feeling like the residents will be like, who the hell is this guy? He knows nothing, with a little bit of like, I got to learn this. I'm like, what the hell is R? We're setting this person to R. R is acute rehab, so I guess it's AR. And BTT was down the tubes. So talking about, a patient who seems to do BTT. Spikes, crumps, opens a gap, bumps his lactate are other, common things. Spikes of fever was certainly used when I was training. Crump opens a gap, spikes his lactate are things, bumps his lactates were things which have, been added in more recent years. Back in the day, a lactate had to go into a green top, which had to be run to the lab on ice. So we never checked lactates, and so never talked about them. And what's interesting about this is I don't want to be completely negative about the language, because it is an extension of a really important step in our learning clinical reasoning. The very first stage of diagnostic reasoning is, I think I actually very first stage in clinical reasoning, we think is sort of what we teach students in the preclinical years, in the clinical pathophysiology course. And it's not entirely clear whether this is how reasoning develops because this is how we teach it or because this is how we have to learn it. But this is sort of where things stand right now. And the very first thing students do is they build these networks based on their knowledge of pathophysiology, sort of obsessed with cause and effect, right? It's learning the disease. The important is that it's a foundational skill. You need to know medicine. You need to know pathophysiology. You need to learn the diseases before you can really do clinical reasoning. Right? We always say you can't reason with an open head, with an empty head. You can't make it to a diagnosis if you don't know what that diagnosis is. But there are disadvantages to it. So this is the idea that, a student goes to see a patient with heart failure, say, and the student has to register every clinical clue, right? This is a patient with long-standing alcohol use. They're coming in with dyspnea on exertion, paroxysmal nocturnal dyspnea, edema. I listen to their heart. They have a displaced PMI. They have a holosystolic murmur. And all of those become individual, individual pieces of data, which the student has to sort of list out and then pull from those and says, okay, what disease have I learned which shares a lot of those characteristics? And while the student is working through all these things, a more experienced clinician, diagnostic reasoner goes into the room and using either illness scripts or instance scripts, talks to the patients for 90 seconds and is like, oh, this person has heart failure. Drives the students crazy. They're like, this is magic, but it's actually the normal progression. And so the reason that none of us do this, except maybe in the most difficult cases, is that it's very slow and it demands a very high cognitive load. You have to keep all of those pieces of data in your head. The next step, which is what the language sort of attests to, is that we abridge these networks. We develop shortcuts for them, which are a change in the way of thinking, but they are also reflected in the way of speaking. So fever, hypotension, tachycardia, and pyuria just becomes urosepsis, okay? And so when we hear a student who says this patient comes in with urosepsis, we make the assumption that all those underlying data points are included there. And we make the assumption that the student, knows what they're talking about and has gathered that information. Morning joint pain involving multiple joints that are warm and erythematous becomes, polyarticular inflammatory arthritis. And so, I can't completely dismiss the terms that we use because they are important in our reasoning. And it's figuring out like, where are these in service of our clinical reasoning and when are they not? Making the arguments that sometimes the way we speak actually truly undermines our relationship with patients. I find most striking when we are sitting in front of a patient and how we speak in front of patients. The patient denied is a great one, right? We say the patient denied something because we're trying to let the listener know that, we know this was important and we asked about it and the patient said that they don't use it. But it sets up attention. Like, how often have you been at the bedside and the patient afterwards was like, wait, I didn't deny that I drink, I don't drink. Why are you saying it like that? Complaint, this is probably one of the things that I have heard back from patients in the era of open notes, where I list the chief complaint and my most, liberated, entitled patients will say to me, what are you saying? I didn't come to you complaining. I came to you, asking for help with this. Compliant, well, do we want our patients to be compliant with their medications? Do we want our patients to be adherent to their medications? Patient endorses, I just have no idea where that comes from, right? Nobody really speaks like that. And then the patient is a poor historian, hopefully seldom said in front of the patients. The reason these terms are interesting is that not only maybe do they interact with the patient interaction or patient relationship, but they really reveal a lot about how we're thinking and often gloss over important teaching points. So a few of the things which make me crazy. So race in the chief complaint, right? I was certainly taught that every presentation started with, this is a 75 white man, this is a 55-year-old Black woman. And, why do we do that? It's seldom a clue to a diagnosis. And if it is a clue to a diagnosis, it probably belongs later in the history anyway. I think we use it mostly as a very imprecise stand-in for the social history that kind of invites stereotyping, right? Because I've told you what this person looks like, maybe you can make a jump to where they live, what their income is, what their profession is, all sorts of things that are probably most of the time wrong and will set us up for stereotyping, making wrong assumptions about this person's exposures, how they deal with the medical field, and probably not worth doing at all. And probably something that, if it deserves a place, it deserves a place in the social history where we talk about what this person's life is like outside of the house. It's also appalling if you're, actually in front of the patient and you're describing someone as, a 65-year-old morbidly obese white man, and you're like, I can see the person in front of us. You don't need to say it. Deferred, the rectal exam was deferred. The rectal exam is always deferred. Deferred means, you've made a decision not to do something that you thought it was unimportant, and that's absolutely fine. I never do a complete neurological exam, right? And so I think we, in presenting and as we teach our students and trainees, say, yes, you should not do an entire physical exam on everybody, but you should say what you didn't do, and you should sort of own that decision. Vital signs are stable. Obviously, the condition associated with the most stable vital signs is death. That kind of tells us nothing. Labs are normal is actually one of the things that I love, because it enables me to be really pithy and nasty and sort of say, why don't you tell me the labs and I'll tell you if they're normal or not. I think I've developed a wonderful talk about like hypo and hyperchloremia, just to make the point that no matter what the labs are, I can say something about them to say, look, you have to think about this. You have to be really careful about what you're telling me. And then, do you want to hear the meds? My usual response to that is like, I'm an internal medicine doctor. Yes, I want to hear the meds. And we lose so much in both teaching and clinical care when things like that are just brushed over, or you're supposed to just look, up on the EMR on the screen and look through the meds. Because they're very, very, very important. I don't know, half the patients who end up on my inpatient service are there because of some sort of iatrogenic injury. Just this summer, I got the presentation of like, do you want to hear the meds? And I looked at them and we moved on. It was a patient coming in with, 4 days of nausea, vomiting, and was hypotensive and had a, hypovolemic hypernatremia when he came in. And it was our pharmacist who said, do you know this GLP-1 was started 6 days ago? And we're like, oh, well, that would be the answer. You also miss a lot, and teaching off the meds, you all know, is wonderful because it enables you to sort of engage learners at every level. You can go through the list and start with the medications and just say to the medical student, okay, this person is on amlodipine, enalapril, and hydrochlorothiazide, what do they have? What are those for? And then you can kind of march up the expertise in your learners to say, what do we worry about with these? What is missing from this regimen, given the medical history that we have? And you're able to teach so much just from a list of medications that the person's coming in on. The histories that we do also in how lazy they often are, we miss really important clues. Poor historian is one of those wonderful ones. Like we have all talked to people who we consider poor historians. We're like, I can't get a medical history from this person, and it's making me crazy. And you can respond to, I didn't get a very good history. The patient was a poor historian by some sort of, pithy comment about like, you're the historian, the patient's not the historian. But I think what's more important is to bring out and say, okay, let's consider that, right? Let's go into that language and say, why is this person a poor historian? Maybe it's the education or intellectual abilities of that patient, which are going to be critical for understanding this person. It's going to be critical for understanding how they're going to follow up going forward. It's going to be critical for how we're going to interact with that patient while they're in the hospital. Maybe it's because they're an incredibly good historian, but they're delirious when you talk to them, and that's why you couldn't get a history. Maybe it's because they're extremely anxious about what's going on, anxiety which may be perfectly well placed, or maybe it's anxiety because we're not getting at the root of their problem. We don't understand what they're actually worried about, and that needs to come out in our history. Or maybe it's exaggeration, right? Maybe they're fixated on exaggerating one thing because they're worried that we're not going to pay attention to them. We're worried that if they don't exaggerate their complaint, we're going to be the fifth physician they've seen who's going to sort of brush over it and rule out cardiac cause of their chest pain, but not actually attend to their chest pain. Or maybe they're exaggerating their symptoms for some sort of personal thing, for being in the sick roll, for getting medications, whatever it might be. Um, Racial comments, it's sometimes great just to ask, so what are you trying to tell me when you tell me this person is East Asian or Northern European, right? I think more often than not, what I get is, I don't know. But sometimes you will get, well, I'm sort of thinking about, late onset or, mildly symptomatic cystic fibrosis, and therefore I thought it was an important part of the history. And like, that's wonderful, great, tell me about that. And then adverse effects of medications we sort of talked about. I'm going to move on to the physical exam. In the physical exam, I think before I get into it, because you're so apt to sound curmudgeon-y when you sort of harp on the importance of the physical exam and how we communicate the physical exam. And the reality is I think, the physical exam, the importance these days is probably overstated, right? 20th century labs, 21st century technology makes a lot of our 19th century physical exam less important than it used to be. I think it's probably important to admit that. It's really the minority of cases that it completely changes our diagnosis. It probably has the most effect in the outpatient setting rather than the inpatient setting, when you're just so overwhelmed by other data in the inpatient setting. For me, I think mostly what it does is it sort of, changes pretest probability a little bit when I use my physical exam. And also, I'll just admit, I train after the days of the greatest diagnosticians. Most of my exams, certainly in the outpatient setting, are used much more to establish a kind of therapeutic alliance with a patient than really to make a diagnosis. I feel like 3/4 of my visits are done after a consultation, and I tell the person, like, why don't you get up on the table so I can listen to your heart and lungs, so I can feel like I'm a real doctor. I also, freely admit, when I take histories, I interrupt patients too early, I interrupt patients too often. I worry about my students being with me because I'm like, I got to get through this clinic, and I'm not doing a wonderful job at modeling open-ended questions with my patients. And then, because most of my exams are about a therapeutic alliance, I list heart and lungs through T-shirts, which is fine if you're just trying to say, I care about you, I'm laying hands on. I promise I never listen through puffy jackets or 3 layers of data. But there are things that I think we do wrong, which send the wrong messages to patients and actually have the potential of truly throwing us off clinically. The first is standing while taking a history. I don't see any reason for anybody anywhere ever to do this. I encourage people to, sit down, get at the same level or even below your patient. I tell a story of years ago. I had a cervical disc herniation playing soccer with my kids and fell flat on my back. And after not knowing what it was, because all I had was some sort of dull aching chest pain, I was in the backseat of a car and I reached up and I got this beautiful, C7 neuropathy. And in the same day, I went to our pain unit because I was like, I need a cervical epidural steroid injection. And then I went to the physical therapist because my internist was like, you don't need that. You just need to go to physical therapy. And the pain unit appointment lasted 10 minutes with the doctor standing the entire time, ended with, a gabapentin prescription, which I sort of dumped in the garbage as I was leaving. And the physical therapy appointment, which lasted half an hour, had a lot of hands-on stuff, but the entire history was done with me sitting on the table, the therapist, sitting in a chair slightly below eye level, clearly attending to everything that I said. And I think just, the therapeutic effect of that history taking was so enormous. That was part of why, I continued to see that physical therapist for a decade and barely even acknowledged the pain doc in the hallway. Also things that we say while we're doing the history. I think so frequently I hear people say, okay, I'm just going to do a very quick heart exam, which I know why we say it. We say it because we're like, we don't want to trouble you. This isn't going to be so bad. I know you've already seen 12 doctors. But often what it comes across as is like, now I'm going to do a crummy cursory examination. And you haven't given the patient the speech about why the physical exam is less important than you learned watching TV shows when you were a kid. And then the kind of random maneuver examination, again, like everything, this is mostly our fault in how we train students. We tend to train students in the head to toe physical examination, and it feels like that's a good exam. But it's not, right? The physical exam is a diagnostic test. We choose our diagnostic tests intentionally. We don't randomly just do every lab in the book. Maybe sometimes we do, but we shouldn't. And so your physical examination is really, I have a hypothesis, I think this person has, HFrEF. And so what my heart exam is going to do is going to be, I'm going to listen for an S3. I'm going to listen for a holosystolic murmur of mitral regurgitation. I'm going to feel the PMI. And with each of those, you're either supporting or refuting your diagnosis. So just choosing some random things makes no sense. I think I came upon this most when we used to do OSCEs for our third-year students as part of their internal medicine final. And there were people who were there, for, I don't know, cellulitis. And the student always felt like there was a few parts of the neurological exam that had to be thrown into the exam. And then a few more, and these are absolutely like curmudgeon-y, I admit. I get obsessed when people do the exam from the left side of the bed. I think we're supposed to do the exam from the patient's right side. We're a right-handed species. All of you lefties, I don't hear about it. This avoids doing the exam in sort of a backhanded maneuver. It also, I think, keeps you, for working with someone like me, from looking like an amateur who doesn't know what they're doing. Again, it's our fault. It's because the attending's usually on the right side. Says, oh, I feel a spleen. Why don't you feel? And doesn't move out of the way. So the attending or student is stuck doing the exam in a weird way. And then abdominal exams, should be sort of, again, slow and thoughtful, not just a couple of jabs. Things that give me some humor is, watching trainees deal with pants and bras, right? You can't do an abdominal exam with someone with pants on, especially as an internist, where there's probably some graph that as people get older, their waistband covers more and more of their torso with every year. And so for someone with abdominal pain, have to have their pants on. My residents know this in urgent care, that I'm going to berate them if I walk into someone with urgent care with abdominal pain in their pants. And watching people deal with bras when they're doing a breast exam is just kind of funny, because to make things easy, they often just try to work around it, pushing it down, pushing it up, ignoring that it even exists. And it's like, a couple of more minutes and you're going to get a better exam. It's going to help you with your diagnosis. There is a few things that sort of, I think we tend to neglect in the history and physical, and realize that the history and physical, the physical mostly, can be kind of traumatic for patients, right? We do an amazing job as a species about adjusting to all of our weaknesses and the effects of aging. We hide those things well. And when we do a physical exam, a great deal of what we do is we're exposing those, right? And so I think we have to be really empathic when we do that, to be sensitive to the patient. Only do these things when it's actually necessary, and then be very cognizant of who's in the room, who are these family members, who are these friends, and think about what's necessary. And that includes things like, removing nail polish, having people take off their makeup, having people take off their wigs to examine their scalp. Like, only when we actually have to do this, not when there are great pictures in the chart, which has already shown us. Neurological exams, especially cognitive tests, MOCAs, things like that, those can be just absolutely horrendous, often more for family members than for the patients themselves. So I pretty much always, if everything else has been done with a spouse in the room, I say like, okay, now I'm going to do a cognitive test, which has to be done alone. So I get the data. And even if you're then presenting the data clearly to the patient, they don't have to see that person who can only come up with, one word that begins with the letter F. And then just to finish assessment and plans, this is just a good definition for sort of diagnostic reasoning. So we're all on the same page. And I tend to set expectations and outline diagnostic reasoning with my diagnostic reasoning yellow card. I'm very fair. I hand out the yellow cards at the beginning of rotations so people sort of know what my expectations are and what I'm going to berate them on. This started as a diagnostic reasoning writ card, but the student on the service said, wait a minute, does that mean if I get this, I can just go home for the rest of the rotation? And I was like, no, that's not what it means. So we switched to a yellow card. And these are things that very often these days, I think we get lazy on. Often they don't matter, but they're good to remind people of, right? So suggesting an evaluation without a differential diagnosis, that's that person has abdominal pain, I'm getting a CT scan. Hold on, let's wait. Let's hear what your differential diagnosis is. Let's make sure that the CT scan is the right test for your differential diagnosis. And if it is, let's make sure that we're doing the right kind of scan. Presenting fewer than 3 possible diagnoses for a primary problem. Sometimes this is just academic, right? Sometimes by the time you see a patient, the diagnosis is absolutely clear, and you don't want the student to waste a whole lot of time talking about, Legionella pneumonia in someone who so clearly has heart failure. But even at the end, just to say, these are the other things that this could conceivably be before we had the chest x-ray, the echo. I love the third one, failing to present an argument against your favorite diagnosis. This is just having people sort of test themselves and say, look, what else could this be? That way you're a step ahead if your leading diagnosis turns out not to be the case. It also makes the student or resident be honest about what doesn't fit here. Like, what are the issues that you had to truly ignore to make your diagnosis fit? And that's because so often, people feel like they have to sell you a diagnosis and everything has to fit. And once you've done this for a long time, you realize that, no diagnosis is perfect, even the ones that are true, right? It's never a perfect textbook presentation. Excluding a diagnosis based on an absence of a sign or symptom. I have a reference down here. We wrote what we thought was this amazing paper. And it is maybe the only paper I've ever written that I could not find a home in the medical literature for it. And so we ended up just publishing it on our Substack. And it's kind of looking at all individual signs and symptoms, looking at their positive likelihood ratios and negative likelihood ratios. And it shows sort of what we know is that positive findings are much, 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 much more helpful than negative findings, right? Positive findings tend to have higher likelihood ratios than negative findings have negative likelihood ratios. And so that's why we sort of follow positive findings to make a diagnosis. It comes up a lot though, because you will hear people say, I considered pulmonary embolism, but this person doesn't have a pulmonary embolism because they don't have pleuritic chest pain. And whenever somebody says something like that, it's important to call them and say, you're wrong. The negative likelihood ratio of basically any sign or symptom is so weak that you should just ignore it. You say, I asked the question, they don't have it. Let's move on to try to find something else. Failing to obey the law of parsimony gets more and more difficult as we take care of sicker and sicker patients, especially in the hospital, who tend to have many things going on. Ranking the zebra above the horse in the zebra suit, right? We're much, much, much more likely to see common things presenting uncommonly than uncommon things presenting commonly. We sort of fixate on that. And then just ignoring the pretest probability when interpreting a surprising test finding. We often these days, I think, are loath to admit that, our lab tests, our radiology reads, even our pathology don't have 100% sensitivity and specificity. So when you have that finding, it's like, oh my God, I wasn't expecting this at all. It's probably that the test was wrong, right? And you maybe should figure out some way around it. I think maybe a good way of thinking about this is to say that, never should a test sort of cinch a new diagnosis. Maybe an unexpected test should just add something high on your differential diagnosis, which then you should consider making the real diagnosis. So I'll circle back to Orwell. A couple of quotes from the end of this piece. That is rather the same thing that is happening to the English language. Let's say it's happening in medicine. It becomes ugly and inaccurate because our thoughts are foolish, a little bit harsh, but the slovenliness of our language makes it easier for us to have foolish thoughts. The point is that the process is reversible, right? So we think about this and we can start reversing our language. Maybe we do better with our diagnostic reasoning. If thought corrupts language, language can also corrupt thought. A bad usage can spread by tradition and imitation, even among people who should know better. We'll take it that that's the history of sort of language and thought. I went down a bit of a rabbit hole on this. Is something that I fully believe. I fully think, we think with language. I think this comes up a lot in our clinical care, right? There are those people who are bad historians, right? Who you ask them to describe their dizziness and they can't do it. And after working on it, you sometimes get the feeling that it's not only that they don't have the language to describe their dizziness, but maybe because they don't have the language, they're not entirely sure kind of what they're actually feeling. It's not just a problem of articulating it, but it's a problem of identifying. Plato said that thought is a silent inner conversation of the soul with itself. Sort of love that. I don't know if he was thinking about language and thought, but I like the quote. Noam Chomsky, if there's a severe deficit of language, there will be a severe deficit of thought. I think that's totally online with Orwell. There is, however, and this was an article in the Times just in the spring about a whole kind of group of research now kind of questioning this and saying, do we really need language to think? Of course, these studies use functional MRIs, and usually functional MRI studies just make you want to scream. But so I dug into some of this research, which was completely painful. And I think what it shows is that there is some very basic, thinking that goes before language, which isn't surprising, right? Infants know that they're hungry on day one, and they don't need language for that. But I think for sort of the more complex issues that we are dealing with on rounds, you need language. I think that might be big. That might be a hill. Here's my George Orwell picture. I was going to grow this mustache for the talk, but I thought maybe that wouldn't go over terribly well. Gotcha. But thank you. So questions? Obviously, a weird talk. So you get across a lot of information. But I'm trying to talk about it. Yeah.
Thanks for the presentation. Just sort of a maybe a left field question. I wonder some of the new AI technologies like ambient note taking. Have you seen any of the output from them? Do they recreate some of these language features of our presentations?
Yeah. And it's funny, so we are, the few things that we've adopted so far are in Epic, having AI sort of give, the first potential response to patient line chart messages, and then beginning to use the ambient AI in the clinic. I have to say, although I never find the responses to my chart messages helpful at all, I am very impressed that they stay, completely away from doctor speak. And I think that's why in the studies that have been done, right, there was that study back in the spring, which took patient questions off some website and then fed them to doctors or an AI bot. And patients have preferred the AI bot answers. And I think it's because the AI tends to be very polite and really speaks in understandable language. It's funny, the ambient technology, I think it's of two minds, if it could be of minds at all. Because it does seem like it's writing for the note, right? And so I think it's been designed to sort of sound like a medical note. And so I do feel like in a lot of places, it is actually just carrying around some of the sort of silly medical notes that we use. Be interesting to talk to, you know, the coders about like, how did you think about this? Because it must have been a conscious decision in terms. That's a great question.
It often seems like to be part of any group that you're new to, whether it's, medicine or military, or even something like sailing, to really be part of it, you have to know the jargon and especially the acronyms.
Yeah.
Sort of put it to that. Try to get away from it, thinking that students thinking they have to talk like that.
I really actually like I love medicine, I love the culture. And I hate to take something out of it that, is important. And I think everybody remembers, no matter if they're doctors, nurses, whatever, those sort of first years after you start training, where all you can talk about is everything that you're learning. And quickly everybody's at the table who's not going through it. It's like, but what I think it is there is a lot in our culture and a lot in our language that is important, right? We are never going to drop, talking about, metatarsal stress fracture, because there's just so much meaning in that we immediately all know what it is. But there is a lot of language that actually maybe supports the culture, but undermines the work. And I think it's that differentiation. But your question, I think, underlines just how complex that is. And maybe we should have someone sitting around who's not responsible for actually taking care of the patient, but who's just responsible for the language to sort of point out those things. It's a cool thought.
So on the, I'm really interested in the sort of the language. And I remember reading an article at some point that looked at the average, the size of the vocabulary of, a 20-something the vocabulary school was like a 30% increase from vocabulary 4 years of medical school. But I'm interested in your thoughts on the therapeutic value of that language. And if somebody comes to me and says and you come up with this thing or so the grammar, and it's very different than if you sort of reading and using language it's like that's part of the visual.
But I think in two different directions, right? I mean, there are those people who come in with something. I've got, a burning sensation on the side of my thigh, and we're like, oh, that's neurological. Lounge from nerve environment. This is why you have it. And that person can be only satisfied with that interaction, kind of because we've named it, maybe also because we've given some prognostic ability, some prognosis. But that is, in a way, what they're paying for. But then there are the ways that, it harms people. Like, how many times have you seen people who are in the hospital with heart failure? We've known they had heart failure for the last 2 years. But then by the bedside, when you say, oh, your shortness of breath is because of your heart failure, and you see, patient and, sibling kind of cringe at it. And I wonder in those situations, it's like, is our language actually doing harm? And do we have to figure out a way to either pull back from it or at least, touch it in a way? This is what we call it. This is why we call it this. It's not like your heart's gonna fail. I guess as you guys, as you ask the question, so the pros and cons of the language, both in the communication and the acculturation in the therapy, come on more and more.
It is, two comments on this that our medical notes documentation and even our presentations used to be to serve patients and other physicians. And now they primarily are to serve lawyers, project managers, billers, coders.
I mean, right, I mean, I think we gotta all agree with the electoral is a different right? And what we all want and what we all stand through, listen, is for the 5 points of like, this is what the problem has, this is what I'm thinking, and hopefully it's been updated, I'm not just copying, and everything is complete trauma. I do think that most of our oral communication, if not billable or discoverable, it's so important, so rich, and maybe even more than that, where there's more and more consultation, more and more handoff and everything. But you're probably right in that the terrible state of the electronic is probably feeding back at worst.
So I think patient encounters. And I find that when we hurry, we often don't do that very well. And there are so many factors that inspire me. And so I find that I have to slow myself down and develop some techniques to slow myself down so that I can be a better human when I go in there. So last right before I walk into the room, then I wonder what are you pursuing? And then I do follow that because we're always running up to I don't want to know that you're not going to do that. So you must slow down. So I just thought and said,